MRD is increasingly measurable these days, either by flow cytometry or next generation sequencing, and it refers to the level of minimally detectable disease or no disease detection, when we call it MRD 0, among up to 1 million cells and finding 1 to 4 cells in a million. And there's data, especially from the frontline trials, that MRD is a powerful predictor for prognosis, for overall survival and for progression-free survival. And getting to an MRD negativity, just as in many other diseases in hematology, is a very effective surrogate goal if you want to get more people to longer survival. So if you can get more people to MRD negativity in a clinical trial, for example, you know that that arm is probably going to win out in the future. So you can read it out sooner with the MRD surrogate endpoint. More importantly, MRD might be the key to eventually curing myeloma, in my opinion, because if you want to truly cure a disease, you have to have no trace of the disease, and you should not have the disease ever come back. And to truly cure the disease, you have to get to a zero disease state, and that the only way we can measure it at this time is by measuring MRD. Finally, I truly believe that some of the patients who are MRD negative right now may actually live out the rest of their lives without ever myeloma relapsing. So I'm very excited about the ability to use MRD these days, and our ability to achieve MRD negativity in higher and higher proportions of patients. On the other hand, we have people who relapse despite being MRD negative. We need to find out who these patients are. And we have MRD negativity may not be the same thing, may not mean the same thing in the relapse setting as it does in the upfront setting. So then again, that has to be taken into account. So there's some caveats when we talk about MRD, but it is a very, very laudable goal for a patient to get into MRD negativity, especially if they're young and if they're high risk.